Hi, everyone, and welcome to Thinking Thoracic, an STS podcast. I am one of your hosts, Erin Gillaspie, and it's my absolute pleasure to welcome you. My colleagues, Hari, Jeff, Jane, and I are so excited to bring you the latest and greatest in thoracic surgery. One of my favorite things to talk about is actually medical oncology topics. And I sort of say this all the time, sort of in jest, but sometimes I wonder if there's some truth to it. I think I might actually be a medical oncologist trapped in a surgeon's body. I love to talk trials. I love to talk drugs. I love to talk biomarkers. And so I could not be more excited to be bringing you updates and downloads from some of our major oncology conferences, new treatments, new trials, and to discuss all of these trends that continue to shape how we care for our lung cancer patients. Today, we are chatting biomarkers and how we as surgeons need to play a really critical role in navigating the biomarker space and really working in a very collaborative and special way with our medical oncology colleagues. I am so excited to be chatting today with Dr. Stephen Liu. Dr. Liu is a brilliant medical oncologist, an associate professor of medicine, the director of thoracic oncology, and head of developmental therapeutics at Georgetown Lombardi Comprehensive Cancer Center. He is also a brilliant speaker, leader in the world of lung cancer, an incredible host of the ISLC podcast, Lung Cancer Considered. Be sure to check that out. Dr. Liu, thank you so much for being here with me today. I can't wait to chat with you about biomarkers.
Oh no, it's my pleasure. Thanks for the invitation. And I think, it's great to have people from different specialties that are really united in the same goal. And I think increasingly we all have to know each other's business, right?
Oh, absolutely. Absolutely. So one of the things that always makes me laugh these days as I'm sitting down in my clinic and writing my notes is they look like absolute alphabet soup these days. I think a lot of people managing lung cancer are starting to feel a little bit overwhelmed. So for my surgical colleagues, what would you say are the key biomarkers at this time for us to be aware of? And how are you using those to sort of select or deselect treatment regimens for our patients?
So it certainly can be intimidating. It's not meant to be, and we do love our acronyms, but it's because there are so many complex words that the acronyms are a lot easier than the Latin words. I promise you. Um, Now, when we think of lung cancer, we've recognized for quite some time that lung cancer is very different from breast cancer, not just from an anatomic standpoint, but from a biologic standpoint in terms of behavior, patterns of spread, prognosis, and increasingly how we treat those cancers. Lung and breast are very different. But we also know within lung cancer, there are a lot of different types of biology as well. In the 1970s and 80s, we saw that non-small cell and small cell behaved very differently, and we're able to craft very different treatment algorithms. But within non-small cell, as our techniques became more sophisticated, as the science grew stronger, we're able to really appreciate and to identify a lot of different subtypes within non-small cell lung cancer. These are molecular subtypes. And so beyond histology, beyond the appearance under the microscope, it really is the genomic changes, the changes in the DNA that define that behavior. And more, they will define the treatment. When we look at the subtypes that we see and we use these biomarkers to guide therapy, it historically has been in the stage 4 setting, where if we see mutations in specific genes, we will direct patients towards targeted therapy and away from immunotherapy. And if we see very high expression of certain proteins, that might send us in the other direction. I think that some of the more common ones, probably the most common one for targeted therapy, is KRAS, KRAS, Kirsten-Rout sarcoma virus. KRAS mutations were discovered quite some time ago, and they define a specific biology. EGFR, ALK, ROS1. These are referring to gene names, and we use that to describe certain types of cancers, cancers that have specific alterations, either mutations or fusions in those genes, will behave a little differently. So if I see someone who has lung cancer with an EGFR mutation, I understand that there's a specific pattern of spread, that there's a specific biologic behavior and prognosis. But more importantly, it guides the medicines we use from the jump. We will direct patients towards an EGFR inhibitor and away from immunotherapy.
I love that. And it's funny because we hear this verbiage a lot. And one of the biggest challenges is that even within that specific mutation. So let's take EGFR, for example. Boy, you can pack so much just even into that. And so I think a lot of people, get excited saying, oh, I have a patient who has an EGFR mutation, but then all of a sudden we're even breaking that down further. And so currently we have drug therapies sort of in the earlier space for LA58R mutations and exon 19 deletions, but there is really just such a huge range of EGFR mutations and treatments being developed to target all of those.
Yeah, we're getting better. I think that as the tools have improved and the science has gotten stronger, we're able to make smaller and smaller slices of these pies. And so within EGFR, you're right. We used to say our common sensitizing mutations were exon 19 deletions and the L858R substitution mutation. For those a little further from the biochemistry, L858R is just leucine to arginine at position 858. And so it's just our old biochemistry tables that we refer to. And we know that those have different prognoses. But even within exon 19, that's not one mutation. That's a family of mutations that all delete a critical portion of exon 19. But all of these tiny differences matter. If we look at ALK fusions or gene rearrangements, these specific breakpoints for the fusion have a huge impact on the biology and really dictate not just which drugs we should use, but we can predict the patterns of resistance. We have very clear differences in progression-free survival based on these small breakpoints of the specific fusion. So it's going to get more complex, not less, but that's better because as we can pinpoint specific behaviors, our treatment can get more and more personalized. And it is going to get a little more complex, but we'll all figure it out together.
And you're right, a lot of this really has been established in the metastatic space, right? A lot of the drug trials sort of evolve in that space and then start to trickle down to the earlier space. And we've seen a couple of those trials not only publish out and read out, but we're having, incredible updates over time. And then now some even trickling into the neoadjuvant space for some of our targeted therapies. Do you mind touching very briefly on sort of the ADAURA, the ALINA trials, and how those have changed how you are thinking about patients in the earlier stage lung cancer space now?
I mean, this is where we want to see the field go. And lung cancer historically has been a late stage disease where we pick up the majority of cases in the stage 4 setting because generally an early stage lung cancer doesn't cause symptoms. But as screening increases, as awareness increases, and frankly, as people are getting scans for other reasons, we are going to find more of these cancers, not to say the least. These cancers are on the rise, and we're seeing more of these cancers sort of globally. So as we detect these cancers earlier, it's going to be relevant in later stages, in earlier stages. So in late stage setting, we first start with molecular testing, and if we see EGFR, if we see ALK, we're going the route of targeted therapy. Those are drugs that are very likely to work. They will work sometimes within days, and they can work for years. It is the right treatment. And there is a right or wrong in that setting because immunotherapy is ineffective. And not just ineffective, if we give immunotherapy and then realize that it's not working, then switch to targeted therapy, all of a sudden, and for unclear reasons, it becomes very dangerous and much more toxic. So we need to make sure we give the right treatment first. Molecular testing, critical. It's not an optional ivory tower academic thing. It is bread and butter. You need the information to pick the right treatment. It is standard of care for everyone. It's part of the diagnosis in the stage 4 setting. Now, for stage 1, 2, for stage 3, we hadn't really been using targeted therapy, in part because we weren't looking for these alterations, because we were still getting a feel for them in the late stage setting, and because early stage was less common. Times are changing for the better. And now we have several studies that show in the early stage setting, after definitive therapy, targeted therapy improves outcomes. So the LAURA trial is a phase 3 study for patients who have an unresectable stage 3 lung cancer and receive chemoradiation. After chemoradiation, they were randomized to targeted therapy, which is osimertinib, a third generation EGFR inhibitor, or placebo. And the osimertinib improved outcomes significantly. We look at the progression-free survival. The hazard ratio was something absurd, 0.16, curves that we never see with anything else, a clear benefit. Similarly, in the adjuvant setting after surgery, patients with an EGFR mutant lung cancer after surgical resection receive chemotherapy up to the investigator and then randomized again to osimertinib or not. The osimertinib significantly improved progression-free survival, and that translated to an improvement in overall survival. Now, one important thing we learned about these trials, not just that targeted therapy keeps those cancers away, that targeted therapy keeps people alive longer, but it tells us that our standard treatment alone was not nearly as good as we thought. When we see someone with a stage 2 or stage 3 resectable lung cancer, and I send them to see you, I send them to Dr. Gillaspie, I send them to a surgeon, our goal is cure. We want to cure these cancers. And we believe we do that for a lot of patients. What we learned from these studies is that EGFR mutant lung cancer is very difficult to cure, that the relapse rates were high, that the control arm in both the surgical and the radiation studies did very poorly. And with chemo radiation in the LAURA trial, we do not cure very many people at all. Our estimates in the general lung cancer population are around 30% cure rate with chemoradiation alone. We're well below that for EGFR. These, again, are different cancers. They're built for early spread. They're built for micrometastases at a very early stage. And so it takes a little more to keep them away. Now, extending survival, as you know, is a little different from cure. And
Yeah.
are we actually curing more people, or are we just keeping that cancer suppressed for longer? I don't know the answer. I also don't know if it's important. We want to cure more people, but if we know this treatment is letting people live longer and live better, I do think it's the right treatment. So we'll continue to evolve in that space, but targeted therapy is now relevant across stages, which means testing is relevant across stages.
Yes, it is. There's a couple of things that I really want to highlight that you just said. So I think sometimes we get so focused on numbers about overall survival. Sometimes we forget to ask and think about how those patients are living their time that they're surviving. And one of the things that I always love seeing at the oncology conferences that I go to is CNS disease-free survival, because CNS disease can be highly toxic, very limiting to patients. And some of these drugs have absolutely incredible CNS penetration and help to really reduce that CNS emergence of disease. And so to me, what a win for our patients. We're not only seeing that beautiful separation of curves, but we're seeing that huge benefit from a CNS standpoint too. That's just so exciting to me.
Yeah, 100% agree. And all of these drugs, if we think of targeted therapy today, for it to be relevant, it needs to work in the CNS. We know a lot of these driver positive, a lot of these mutated cancers have a tropism for the brain, a high risk of brain mets. Tells us we need to watch for those. If I see anyone with an EGFR mutant lung cancer going to surgery, they're getting an MRI first because a very high risk of spread there. And we need to monitor those areas. Again, in those control arms, we see the CNS as a site of common relapse. We can prevent that with these drugs. And I think it's a really important point. Progression, the active progression, doesn't tell the whole story. If we see local progression or an isolated lung nodule that we can treat with stereotactic radiation or with another surgery, that's very different from a solitary brain metastasis. And brain metastases in particular can be devastating. Recurrence of lung cancer in general can be very unforgiving, and a lot of times we don't get a chance to treat the cancer if it recurs. There's a lot of attrition with this disease. It's progression itself can be a very violent thing. So if we can prevent that from happening, I think we help our patients.
Absolutely. Absolutely. The other really important thing I want to touch on and sort of discuss just a little bit further is your comment related to the wrong treatments in the wrong order, right? And this is something that I think is critical as we have this just really exciting wave of neoadjuvant chemo immune checkpoint inhibitors. And so there is a lot of momentum there. We have multiple trials now, right? We have our Checkmate 816, we have our Keynote 671, we have our AEGEAN, we have our Checkmate 77T. We have our first evidence with our, Keynote 671 of overall survival benefit. Just behind that, we have Checkmate 816 overall survival benefit. So there's a lot of people saying, hey, we got to get these patients onto these regimens. And I think sometimes they're doing it and forgetting to look for the EGFR mutations. And so these patients are getting chemo IO up front. And there was that beautiful study that came out showing that really, truly, there's increased toxicity when giving, in particular, a drug like osimertinib after the immune checkpoint inhibitors. And we know that the EGFR mutant patients, some cohorts of them are much less likely to respond to the immunotherapy. And so we've sort of given the wrong treatments in the wrong order, and now we can't give the right treatment as efficaciously. And so I'm so glad you brought up that point, because I think sometimes we forget about that in our excitement about some of these new immune checkpoint inhibitor trials coming out.
Yeah, we don't understand why it happens, but it
Yeah.
seems to happen pretty consistently. And if you look at these EGFR inhibitors, they're safe drugs. People feel well, they live normal lives. We interact with these people in our day-to-day business, but these safe drugs can become very unsafe if they're given after immunotherapy, the whole point of immunotherapy is durability. That when we give a PD-1 or a PD-L1 inhibitor, our hope is for durable benefit, long-term benefit, remodeling the immune system so that it's not a friendly environment for these cancer cells. And that durability applies not just to efficacy, but to toxicity as well. We know that we can't give the drugs together. They have sort of these dangerous interactions where we see high rates of pneumonitis, colitis, other very toxic immune-related adverse events. So we can't give them together. But if you give a checkpoint inhibitor first and then give a TKI a month or two later, functionally it's the same as giving them together, because again, this drug is a long-term durable medicine, so its effect can go on for months, for years. I've had patients where 6 months later we start the TKI and then all of a sudden we get really severe toxicity. So ideally, you don't want to paint yourself in a corner. We don't want to burn any bridges. We want to really make sure that first step we take is the right one, and that we're not putting ourselves and our colleagues and our patients at unnecessary risk. So in my mind, knowing the EGFR status, the ALK status, really that is part of the diagnosis, that we know that lung cancer, that's not good enough. We need non-small cell or small cell. Well, we also need to know that mutational status, and it's not going to be long before that is included in our agency staging systems as well.
I love that you mentioned that this should be part of the upfront diagnosis, because I want to dive into how to have a successful biomarker program, right? So there's a lot of movement into this earlier stage setting. We need this information earlier and earlier. How are you guys handling this? Are you sending all of your molecular testing on the index biopsies that you're getting from pulmonology? How are you working with your pulmonologist to make sure that you're getting enough? And how are you navigating this space to get that testing done in a timely fashion?
Yeah, so this is critically important. I think we're all learning together the best way to do it. It's going to be easier as the technology gets better, but you highlighted some really important points. First, that testing needs to happen right away. And here we are on the clock, right? When we see somebody who's diagnosed with lung cancer, I guarantee you they're going to track back their symptoms a couple months. They're going to say, look, it's taken this long for me to get a diagnosis. So you're already behind the eight ball. This patient wants treatment tomorrow. And so it takes some time to really be sure we're getting the right treatment. And we can explain why neoadjuvant is a better approach than going directly to surgery, that we're improving outcomes with early therapy. But then to say we want to do neoadjuvant therapy, but let's wait for molecular testing. Let's wait a month before we start that. There are very few patients where that's going to be acceptable. So we need to make those processes more streamlined and faster so they don't take a month. Yes, we are doing testing on the index biopsies, but it does require close collaboration, not just with our pulmonologists, but with our pathologists. And so we're all on the same page. Our pathologist, a small fine needle aspirate with one pass, that's not going to do it. That used to do it, it's not going to do it anymore, because squamous or adeno, not enough. I need molecular testing. I need PDL1 status. I need more tissue. And from the pathologist, who love all their immunohistochemistry tests because they give so much insight into the character, and they can learn so much from it. But we are going to need to resist the temptation to do that. We are going to go into conservation, Great Depression mode, spare every slide so we can do our tests. Every micron counts. So we need to be very conservative with that. But this requires open communication, and it requires relearning, which, as we know, is very difficult from learning the first time. If we go back 20 years ago, it's the opposite, right? Diagnose with the least invasive, lowest risk procedure, the smallest needle, the most accessible site. And as soon as you make a diagnosis, get out. No longer the case, because the mutation status is part of the diagnosis. And using a small needle and getting a small amount of tissue, yeah, it might reduce the risk on this procedure, but we're going to end up needing to go back and do a second procedure. And so now we've increased the risk log fold. So we need to make sure we're getting a lot of tissue. We're smart with the tissue stewardship, that we're conserving that tissue, sending it right. And then we need to find a way to send that tissue immediately for the proper testing. Now, at our institution, that's next-gen sequencing, because we do look sort of like to cast a wide net. We like to look for multiple drivers at once. I think I learn a lot from that. Now, you could make the case that the most relevant molecular tests here are EGFR and ALK. And EGFR can be done with PCR, polymerase chain reaction, which requires a small amount of tissue, which can be done very quickly, and ALK, which can be done on immunohistochemistry or FISH. And so you could do single gene tests. Those can often be done locally, sometimes with a 1 to 2 day turnaround. That's not the wrong approach. And that's the approach that many take. our approach is next-gen sequencing because I do think the principles extend, but I don't have a lot of evidence to back me up there. I don't think there's anything wrong with doing those single gene tests in that setting. We want to know EGFR and ALK, again, because not just for esoteric purposes, not just for prognosis, because it's guiding our first step. And while we won't be using targeted therapy in these settings, it'll help us deselect patients for immunotherapy. It'll steer us away from immunotherapy, which might have negative consequences in the future in terms of delayed reactions, but also we will spare those patients immunotherapy because it's not likely to work. It's not really going to help those patients. It's unnecessary risk, and we'll go down a different path.
I love that. So to kind of summarize all of those thoughts, we definitely want to get EGFR. We definitely want to get ALK. We definitely want to get PD-L1. But there's a lot of different ways to do it. And I think that adds to some of the complexity as we go to these meetings and have conversations. There are a lot of different platforms. There's in-house testing, there's out-of-house testing. There are wonderful companies to partner with. And then there's the single genes versus the huge panels. We similarly have gone with the larger panels. We have great relationships with the companies that we use here locally. We feel like our turnaround is pretty fast, but it really does take a very judicious effort from partnership between oncology, surgery, and in particular, our bronchoscopists who are getting a lot of these specimens for us now. Really, they do such a wonderful job now increasing their number of passes, making sure that they've got good cellularity to try to help answer these questions for us. But every so often, we end up in that really challenging situation where we have just enough for diagnosis and not enough for molecular testing. And that's when I start to hear people coming out of the woodwork saying, do we biopsy again? Do we do liquid biopsy? What do we do? How are you handling those cases in the earlier stage setting where we may not have very large tumors? We may not have tumors that are high shedders. Are you going straight to liquid biopsy? Are you doing more tissue and liquid at the same time? How are you navigating that challenge?
Yeah, this is a challenge, and there's not a clear right answer here. As the technology improves, we'll be able to do more testing with less tissue, and so that'll help us a bit. Liquid biopsy is something a lot of folks do. I think there's very low risk with liquid biopsy, but it lacks very good sensitivity in the early stage. And so tumors are less likely to shed, you're less likely to find the alteration, and the negative result doesn't prove that there's not an alteration there. So I think there's little harm with doing it other than potentially a financial toxicity. But very often, I think it doesn't give us the right answer. And increasingly, we will go back and repeat the biopsy. But now that's a big ask for everyone involved because this is the curable setting. And our biggest fear is that we see someone curable, and by the time we send them to their curative procedure, the cancer is already spread, where we've lost that window, where that window for curability has closed. That's something that keeps you and I up at night, I'm sure. And so how do we compromise that? How do we sort of address that, not just the concern, but the real possibility? And one thing that we would do in that setting is if we needed to go back and repeat that biopsy, we'd say, we're going to do this biopsy, but we can't keep waiting. Let's go into a cycle of chemotherapy alone. Neoadjuvant chemo alone doesn't introduce the risk if we give a targeted therapy afterwards. We can walk back from that. We can get a clean slate. It's probably part of our treatment anyways, if we're thinking of neoadjuvant therapy. The real question is not about the chemo, it's about the immunotherapy or targeted agent. And so we can do the chemotherapy alone. That buys us 3 weeks. And so if we're anxious, if we want to get started, chemo alone is a good option. We've been doing it for a long time, and we can always add the immunotherapy with the next cycle. And I think there's a very little harm done there.
I love that thought process of starting the treatment because we all feel a sense of urgency. We have to start the treatment. Patients feel that sense of urgency and a lot of unrest until we have a plan. And so starting a treatment that we know works, that we know is going to likely be the backbone of a therapy, and then adding to it as we clarify what's best for the patient. I mean, that's a beautiful way to take care of people. I love that.
It's nice to do that testing early too, especially in the unresectable setting. If someone has
Yes.
unresectable and we're going to go through chemoradiation, this potentially is our only opportunity to do a biopsy, because after chemoradiation, that biopsy is not going to be very helpful, especially if that treatment has worked as well as we want it to. You're going to get necrotic tissue. You're not going to have enough DNA. And then that testing window is gone. And now we don't know what treatment to give. And so we're kind of stuck. So we really want that information up front. We don't want to handicap ourselves in making the best decisions for our patients. We need that information because if we don't have it, we're guessing as to what the right treatment is.
Yeah, absolutely. Absolutely. Now, one of the reasons that I've seen people in some cases shy a little bit away from sort of big, broader gene panels is two things. One, there could be a little bit of added cost, a little bit of added time with running sort of the full piece. But I've also candidly heard from colleagues that you get this very comprehensive report back, some of which contains meaningful information about mutations that we know that we have treatments for, we know what to do with, but sometimes it contains a lot of details about mutations that we actually don't fully understand or we don't have a target for. And I'll tell you, our cancer patients are so savvy. They are looking these up. They are calling our offices saying, hey, I see that I have XYZ mutation, and what do you have for me? How are you navigating sort of this space where we have targets for some areas, lack of targets? We know more about the mutations constantly. What resources do you use? What do you recommend for us?
Well, I would disagree with a little bit of the intro there,
Yeah.
where you said sometimes we find something that is a little complex. I would say we always find something that's very complex, and a lot of us are not molecular biologists. I'm not, and so especially for our colleagues that maybe did their training a little earlier, this is all new, and so
Yeah.
it's not that this is evolved. This is an entirely new field. This wasn't even
Yeah.
taught to oncology in our lifetime. It wasn't even taught to surgery in our lifetime. These are new concepts. And so, number one is don't be afraid to ask for help, that we're learning these concepts. If you want to stand up and say, look, I don't really understand the difference between DNA sequencing and RNA sequencing. I don't, we are happy to talk about it. I know people that would kill for the chance to just talk about that for hours to you if anyone would listen. So there are people that love to talk about it. Don't be afraid to ask for help. Don't be afraid to attend webinars, seminars, lectures that are teaching these. We want to make this accessible. It's a new language and it takes a little while to learn it. Second is that no one knows all of these things. So don't be afraid to ask for help. Now, who can you ask for help? You ask your friends, and I can, share with you that I think every thoracic oncologist has a text chain or a WhatsApp chain of people in different areas where we run different alterations by each other, and we certainly don't remember all of them. Ask the platform, ask the company. They have bioinformaticians, they have experts that are willing to walk you through that, to guide you through what this alphabet soup means. And as you're in the field long enough, you'll begin to sort of recognize which ones are relevant and which ones we don't really know a whole lot about. You'll see VUS described a lot. These are variants of
Yes.
unknown significance, and we don't know. And sometimes later on, those end up being very significant. We just didn't know at the time. That's also important because the field is changing so quickly. You can see someone whose report was a few years old, and now those alterations may have a totally different context. We may know a lot more about sort of what those mean. And there's also a difference between what we think is happening, cutting edge, sort of emerging evidence versus true standard of care. And I think the field is changing very quickly. And we look at different outlets like our conferences, like our CME events, like podcasts like this one to really try to stay up to date with these things. EGFR and ALK, those are areas where we have targeted therapy where immunotherapy is largely ineffective. I would lump several other ones in that same family: RET, ROS1, NTRK, NRG1, HER2. These are alterations that are largely in people without a smoking history. And so, really, a clearly different biology. Whereas other alterations like KRAS, which is probably the most common, those often will occur in someone with a smoking history. And even though it is a genetic change, even though it is something where we have a molecular target, those are people where it absolutely is appropriate to do immunotherapy. And so it's not always so intuitive. We shouldn't feel bad if we don't know the clear answer right away, because there's a body of evidence that's being generated for each of these alterations. So the easiest advice is really ask for help. Don't be afraid to ask for help. And we need to partner together. Where if I have a patient with a resectable lung cancer that's going to surgery, they get neoadjuvant, we go over these alterations together. The surgeon and I, we really are a team, and we both are going to play a role in helping to try to cure this patient.
Absolutely. And for me personally, beyond my incredible medical oncology colleagues like yourself, one of the richest things that I have had the opportunity to participate in is the ISLC TTLC meeting, which I was invited to by one of my medical oncology colleagues for the first time 7 years ago. And it's become one of my favorite conferences. And I just sit there and absolutely nerd out with all of my favorite people on all of these new genetic alterations, mutations that we now have a better understanding of, and we've developed a drug for, and we think we're starting to unlock it, and we see the potential. And it's just, what an exciting time to be in this field.
Yeah, well said. I think it's very exciting. We're in a field where medicinal chemistry and synthetic biology are taking us to the next level, where we're not just choosing sort of random compounds we see in nature, where we're seeing the need, what are the vulnerabilities of this cancer, and building the drugs that are going to fit that cancer properly.
One of the biggest challenges that we're facing as surgeons, and you sort of hit the nail on the head when you said we have to talk about these patients constantly, is we also don't have any data to say when it is safe to operate as we start to move some of these new agents into the neoadjuvant space. And it's actually a really common phone call that I get, patients in particular who've been treated currently in the metastatic setting, and they've received a particular drug, and now they have single site progression or single site residual disease, and we're planning a surgery, and we're thinking, gosh, how long do we hold this drug? What timing is it safe to resume it? And we've seen some of the data starting to become available with Neodora, hopefully more information later this year to understand how moving osimertinib into the neoadjuvant setting sort of impacted surgical findings, the surgical conduct of surgery. But I think that just continues to deepen the relationship that we have with our oncology colleagues to navigate how and when we can operate with these new drugs.
Yeah, I mean, we don't want to do anything that's going to compromise safety. So anything that might interfere with wound healing, increase the risk of bleeding, these are things we want to avoid. And I do think that we're historically pretty conservative when it comes to that. Do no harm, of course, is our credo. But I think a lot of these drugs can really be given pretty close to the time of surgery, and we will continue to evolve a little bit more. We're learning from the stage 4 space, and one of the early things we learned way back when Dave Jackman described these early phenomena of targeted therapy was the potential for flare. And so when we think of the stage 4 setting, if someone has an EGFR mutant lung cancer, they're responding well to a drug, and then it stops working, what we used to do is then move on to a different drug, maybe a different clinical trial. These trials often have a washout period where patients won't be on any medicine for 4 weeks, just so we're sure there's not any overlap. We're sure that we have a fresh, clean slate. And what we saw is even though the cancer was growing when we started to hold the drug, the growth accelerated off of the drug. That even though the drug wasn't working perfectly, it was still doing something. It was still holding back a lot of that cancer. And when we stopped it, we saw these flares of disease in the subset of patients that, unfortunately, in some cases were fatal. And so these drugs can sometimes lead to a rapid regrowth of cancer because in some cases, they are just suppressing a lot of the clones. We take our foot off the brake and those cancers can sort of grow back fairly quickly. Now, generally, we feel that a 2 week period is completely safe in almost every circumstance. And so I wouldn't have concerns that, but it's not a setting where we want to hold drug for 6 months and then start treatment because we're going to lose all the ground that we might have gained.
Yeah, absolutely. Absolutely. A lot of complexities. And actually, one of the things that I'd love to touch on, which has a little bit of complexity to it, but I sort of hear a lot of people describing immunotherapy and the thought process with that being a little bit more sidle, and with some of the targeted therapies being a little bit more static, right? We know that there's this mutation. We know that we can keep it under control with a drug, but we know that withdrawal of that drug could allow for proliferation. And you sort of alluded to that. Is that how you're thinking about some of these drugs and in particular targeted therapies? Because that gives me a lot of pause when we're thinking about taking patients off of treatments. Is it right just to do 2 years of treatment, 3 years? Should we be doing 5? I don't know that there's answers, but what are your thoughts?
Yeah, I think that in the current form, we think that these targeted drugs don't cure many people. We try to avoid absolutes, but I do think that when we look at immunotherapy, some of the results we're seeing in these early neoadjuvant spaces
Yeah.
really is pretty remarkable. That we're seeing
Yeah.
pathologic complete responses that are durable. We're seeing people that truly are cured of their cancer. With using immunotherapy. And so I think these are really powerful treatments. Whereas if we look at neoadjuvant targeted therapy, the rate of pathologic complete response rate is pretty close to zero. It's not something we typically see. We can see radiographic responses, but the pathologic response is usually incomplete. Whereas in immunotherapy, it's usually not a complete radiographic response. We still see tumor on the CT, and then our pathologist says there's nothing viable left. So it's a little bit of the opposite. In the stage 4 setting, targeted therapy is our standard, but we don't really cure people with targeted therapy. And I would say in its current form, I
Yeah.
think that eventually we will get there. I don't think it'll be one drug, and we have to understand a lot more about persistence, about the survival of these cancers, about how these cancers are entering this remission state, and how they're sort of developing resistance and allowing themselves to survive. So as we understand the processes that these cancer cells are triggering that allow them to survive through these TKIs, we can develop sort of rational personalized combinations that will be more cidal, that will be able to eliminate these persister cells, these small populations that have sort of entered into this hibernation. So I think that eventually we will get there. And when I think of neoadjuvant therapy with targeted agents, we're not
Yeah.
seeing complete responses. And those are settings where it might just end up being neoadjuvant chemotherapy, surgery, and then let's use targeted therapy later in the adjuvant setting with an open end on durability, because again, we don't know if these are eliminating cancers completely, but I think we'll learn a lot from that neoadjuvant setting. So if we give someone a targeted therapy for a few months, you remove that tumor, we see, okay, 70% of those cells have persisted. Now I can understand, how are they doing that? What pathways have been triggered? How are these cancers surviving these cells? And that can inform the next wave of combinations to really try to prevent that from happening. So I think that's where the field is going, not just for patient outcomes today, but really for our patients of tomorrow.
A lot of exciting new drugs coming down the pipelines. What biomarker and what drug are you most excited about right now?
So I really like some of the ADC work. Antibody drug
Yeah.
conjugates are a way to really focus the chemotherapy, and some of the work that was presented at the WCLC from our colleague, Dr. Tina Cascone, showed that introducing an ADC in the neoadjuvant space really pushed that pathologic CR rate even higher, and the mechanisms by which that works maybe make it a good partner for immunotherapy. But we're looking at our biomarkers getting a little more sophisticated there as well, where it's not just presence of a protein on the outside, but the way that ADCs work is the internalization. So can we now measure the internalization? And Dr. Marina Garacino presented a new biomarker that's a very different type of biomarker, where basically you're taking a digital slide, you're uploading it, and then using a deep learning algorithm to tell us, beyond the human eye, is this drug going to work? And it was a very powerful predictor for these ADCs, matching the specific mechanism of action. And so I do think that machine learning is really going to inform this next wave of digital biomarkers. I think that's where the field is going, and we should be able to get that information very quickly, where we upload digital micrographs picture, we do a biopsy, we have a digital H&E, we upload that. The next day we can know exactly what drugs are going to give us the highest chance for pathologic CR. I also am interested in dynamic biomarkers as we go, pharmacodynamic markers that tell us, are we on the right track now, or do we need to pivot? Where we would give 4 cycles of neoadjuvant therapy, but what if after 2, you did a blood test, you did a CT scan, you did a biopsy that told us, hey, you're not going to get there with this approach. You need to pivot now, because if we look at ctDNA, for example, clearance of ctDNA proved to be a very powerful predictor, where if you did not clear, you were not going to achieve path CR. You had no chance of getting path CR. And if we know that after cycle 2, why keep giving that same treatment? Why not pivot and give us a chance at something else that'll get us better? So it's early markers and it's markers in the middle that really reassure us. And then, of course, the holy grail here is going to be MRD, is minimal residual disease after you resect the tumor. Is that patient cured at that moment? And if you can tell me that there is 0 cancer in the body, well, I shouldn't need to give any adjuvant therapy. That'll spare toxicity, that'll spare cost, that'll give us that peace of mind. That's a true cure. And then if we can see a test, nope, there is still treatment there, there's still cancer there, we need more treatment, we need adjuvant therapy. Now we determine what therapy we need. And then later on, did we eliminate all the cancer? And this is really what we're looking for. We are not there yet. We have a lot of things that we think are getting closer. We need a little more time, but that's really going to make a huge impact, not just on how to treat patients, but when to treat patients.
Ah, so exciting. And I think that, well, first of all, I'm already excited about the digital biomarker prediction. I mean, that's just incredible. And, with the expansion in AI and everything that is coming down the pipelines, gosh, you have to think that we're probably not too far away from being able to make that a reality, which is so exciting. And also, it seems like so many clinical trials are really incorporating the ctDNA, using MRD to start really trying to make those treatment decisions and start to understand the phase of contribution and the degree of contribution of each phase of care, which I think is really important to avoid the cost of toxicity. Our patients, they want time away from therapy when possible and when achievable. And so continue to strive for that, I think is extraordinary.
No, absolutely. We can really widen that therapeutic window if we can start with who needs treatment in the first place, because
Yeah.
some people are cured with
Yeah.
chemotherapy and surgery. You've cured many people in your career. And so tell me up front, who are those people so we can, reassure them, so we can spare them the toxicity of other treatments and really focus our efforts on the people that need it.
Amazing. I cannot thank you enough for your time today. Do you have any final closing thoughts, things that you would love to leave our listeners with?
Keep it up. I think that the field is growing, but we're going to learn it together. The medical oncology group, especially, I think the thoracic space is very welcoming of people of all specialties, and so come to all of our meetings. Find Erin or myself, and pull up a chair, and we'll learn it together. And I will tell you that a lot of it is a little repetitive. There are a lot of patterns, so you can get caught up, I think, pretty quickly.
And hopefully this podcast will get them a long way on their way to that, which will be incredible.
Absolutely.
Dr. Julie, thank you so much for your time. Thank you for your expertise. Thank you for joining our podcast. Wishing all of our incredible listeners a wonderful rest of the day. Thank you for joining us. Let's get out there, spread the word about screening, spread the word about making sure we're taking the best possible care of our lung cancer patients. Let's talk to them about biomarkers. We are equally important in that conversation. Keep taking extraordinary care of people. And as always, keep smiling. Thanks, guys.